Good afternoon, everyone. This is Margie Giuliano, the Med Safety and ADE Regional Lead for the New England QIN-QIO, and I want to thank you for joining us for today's webinar entitled Exploring Diabetes Self-Management Education, a tool to enhance care transitions and reduce adverse drug events. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. The recorded presentation will be available within a few business days after the webinar on our website. The phone lines will be on mute during the presentation, but we will unmute the lines after the presentation for questions. I'll give some instructions on how to ask questions at that time. Although the lines will be muted, we still would like you to actively participate during the session by using the chat function. My colleague Nayara will be monitoring the chat window and responding to your comments. So don't be shy. We'd love to hear your thoughts about what our speakers are saying and how you're addressing med safety and diabetes initiatives in your own practice. It's important to note that today's speakers have no conflicts of interest to disclose. Our speakers today are Attorney Jennifer Raymond and Dr. Milagros Abreu. Jennifer Raymond is the Director of the Healthy Living Center of Excellence, a division of Elder Services of the Merrimack Valley in partnership with Hebrew Senior Life. Healthy Living Center is the statewide hub for dissemination of and contracting for evidence-based self-management programs in Massachusetts. In this role, Jennifer is responsible for strategic planning and sustainability, overseeing an 80-plus member provider network of community-based organizations, as well as all efforts to integrate these programs with a variety of healthcare payers. She serves on the Executive Committee of the Massachusetts Healthy Aging Collaborative and is a member of the National Evidence-Based Leadership Council. Dr. Abreu is the President, CEO, and founder of the Latino Health Insurance Program. She is the Chair of the Massachusetts Medical Society Committee on Ethnic Diversity and an Executive Committee member from the Healthy Aging Collaborative and Steering Committee member for the Massachusetts Comprehensive Cancer Prevention and Control Plan. She's dedicated her career to ensure high-quality and accessible primary care for minority residents. The Latino Health Insurance Program has assisted 40,000 families with access to health care, chronic disease prevention, federal nutrition programs, and disease management. The learning objectives for this program are to recognize that patients with diabetes and those on diabetic agents are at higher risk for hospital utilization and adverse drug events, to review the Stanford Diabetes Self-Management Program, to explain how to incorporate DSME Referral into workflow, and to identify benefits that individuals receive through greater engagement and self-management. As I shared, during this call, we want you to use the chat feature so we can hear from you. So please chat in with questions and comments on the presentation, your initiatives and experiences, as well as what you might need some assistance with. So please, let's start by seeing who's on the call. Type in your name and role, organization, and state. As most of you know, diabetes is one of the most common diseases in the United States. In 2015, the CDC estimated that 9.4% of the population, or 30 million people, had diabetes. It's the 7th leading cause of death in the United States. Medications used to treat diabetes may cause low blood sugar, also cause hypoglycemia, which is the 3rd leading cause of adverse drug events. Lack of and inappropriate treatment of diabetes is a major burden to healthcare expenditures. The total direct and indirect estimated cost of diagnosed diabetes in the U.S. in 2012 was $245 billion. When accounting for other factors, that is about 2.3 times higher than expenditures for people without diabetes. According to the CDC, it's estimated that 1 in 3 U.S. adults will have diabetes by 2050. Those are staggering numbers. Patients not properly controlling their diabetes are at a much higher risk of developing cardiovascular diseases such as heart attack and stroke, retinal degeneration leading to blindness, decreased kidney function, and skin infections that may progress to amputation. There are many medications that can be used to help control diabetes. However, two classes present the highest risk of causing hypoglycemia, which is the largest risk of adverse drug events with this class of medication. These two classes are the insulins and sulfonylureas. Patients on diabetic medication regimens that combine these two classes with other agents are at the highest risk of developing hypoglycemia. Low blood sugar may cause confusion, loss of consciousness, and falls leading to broken bones or bleeds. The risk of hypoglycemia is increased by changes in diet or physical activity level, medication interactions, and polypharmacy. It is important that patients are educated about the risk of hypoglycemia, how to treat it, and the importance of adherence to prevent progression of the disease. When we look at hospital utilization, we learned that nationally, in 2014, a total of 7.2 million hospital discharges were reported with diabetes as any listed diagnosis among U.S. adults aged 18 years or older. These discharges included 1.5 million for major cardiovascular diseases, 108,000 for a lower extremity amputation, and 168,000 for diabetic ketoacidosis. When you look at the emergency department visits, in 2014, a total of 14.2 million ED visits were reported with diabetes as any listed diagnosis among adults aged 18 years or older. These visits included 245,000 for hypoglycemia and 207,000 for hyperglycemic crisis. So you can see that the management of diabetes is critical for people affected by this disease to live a healthy life. As you can see from this graph, when you look at claims data from Medicare fee-for-service, you will see that beneficiaries with diabetes have a higher 30-day readmission rate compared to non-diabetic Medicare fee-for-service beneficiaries. This slide reflects claims data for New Hampshire Medicare fee-for-service bennies 30-day readmission percentage for the calendar year 2016. Medicare beneficiaries with diabetes readmission rate was 20%, and those without diabetes was 15.7%. And when you look across New England, you'll find similar results. I think this graphic really captures the current discharge process for patients. More like blah, 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 and whatever you say, Doc, I'm good to go. I think that's the general consensus. Patients really are focused on getting home. What we know from our readmission work is that there are three main drivers for poor transitions: failure to implement standard and known processes, unreliable or incomplete information at transfer, and limited patient activation. Patient activation is critical for patients and caregivers living with diabetes. Improving patient understanding of their condition and encouraging ownership and engagement is a must. We should provide our patients with the skills to manage symptoms of the disease like hypo and hyperglycemia, fatigue, stress, pain, and emotional issues. They should be educated on the importance of appropriate nutrition and diet, and they should be counseled on the correct use of their medications. Recognizing the significant opportunity to impact patients with diabetes, CMS launched Everyone with Diabetes Counts, a diabetes self-management and education program offering evidence-based diabetes self-management training. The program is designed to empower and engage beneficiaries and families in their health care through knowledge, to partner with others to provide diabetes self-management training with special focus on the medically underserved in vulnerable populations, to improve clinical outcomes for patients with prediabetes or diabetes, and to increase the number of trained DSMP teachers across New England. This will assist in ensuring sustainable diabetes education resources at the community and state level. While the DSME program the QIO offers is funded by CMS and free for Medicare beneficiaries, we promote and collaborate with others in the community who offer similar programs. As part of this effort, we are tracking our progress and initial results for the QIO offered programs. As of April 31st, 2017, our programs were completed by 1,351 individuals. Initial results show improvement in knowledge, coping abilities, and behavior patterns. This demonstrates the potential benefits individuals gain from being engaged in their own health. In addition to the patient perspective, we're also looking at clinical outcomes and utilization, as we believe that engaging patients in managing their diabetes will improve immediate clinical outcomes, weight, and hemoglobin A1Cs, and also avert adverse events, including emergency department visits and hospital stays. To that end, we're very excited to have two of our partners in Massachusetts with us today to talk about their programs and initiatives. I will now hand over the presentation to Jennifer Raymond, who will go into more detail about her program. So Jennifer, I'm handing it over to you.
Jennifer, just make sure to unmute yourself by pressing #6 on your phone, or make sure that the mute button is not pressed on your phone as well. Jennifer, are you there? Again, make sure to press #6 so that we can hear you.
Hi, I'm sorry. I pressed #6 a couple of times. I hope it's worked this time. Can you hear me?
I've got you this time, Jennifer. Go ahead.
Thank you very much, and thanks everyone for your patience. Thank you, Margie, for that introduction. Now that Margie has given us a really good picture of why it is so important that we address the diabetes epidemic, I wanted to spend a little bit of time today talking about the partnership that we have brought in Massachusetts to HealthCentrics and the New England Quality Improvement Organization Quality Improvement Network to address diabetes through a community and clinical collaborative. When Margie was talking, she gave us some really nice statistics. Nice statistics as to the real challenge that we have, and there certainly are many more people out there with diabetes than we have the capacity in clinical systems alone to address. And folks like the Surgeon General and the Center for Disease Control and Prevention, the Administration for Community Living, the National Council on Aging, we have all sort of talked about the importance of creating community and clinical linkages in order to address the diabetes epidemic. And the Everyone's Diabetes Counts initiative is designed to do specifically that. Not only to bring programs to people with diabetes in places that are convenient for them to attend, but to really have these programs address the social determinants of health. They're not to take the place of clinical programs. They're not to take the place of the really important clinical care that folks receive from their healthcare providers. But as we know, many of the factors that impact an individual's health are not related to the clinical care or not related to their genetics, but are instead related to their environments, whether that be the physical environment, the social environment, their behaviors. So the chronic disease self-management programs that are specifically targeted towards diabetes are designed to address those social determinants of health with folks and to help them increase their self-knowledge, their self-confidence, so that they can begin to start making small incremental changes to impact not only their health, but their overall life and the choices that they would like to make in order to maintain the level of quality of life that they currently have. These programs are also designed to work for multiple diverse populations, and at the end of the day, they are designed to improve health and decrease the cost that we all know is overwhelming for the system. So the particular program here in Massachusetts that's part of the initiative is the Stanford Diabetes Self-Management Program. It is a 6-week intervention that happens in community settings. Many of them are at senior centers or independent or assisted living. They often happen at the YMCA, faith-based organizations, multicultural institutes, essentially any place that older adults or adults with chronic conditions naturally congregate. The chronic disease program that focused on diabetes is targeted for adults living with type 2 diabetes, and it certainly is an investment for these adults. It's not a sort of drop in and out program and get a little information, but instead it's a commitment, 2.5 hours a week for a total of 6 weeks, and the program is very interactive. So it's not going to be a clinical professional giving lecture or giving just information to older adults, but instead it's going to be led by 2 trained lay leaders, at least one of whom has diabetes and is living with diabetes, and it involves a large amount of discussion and problem solving. So it's very different than what we oftentimes think of as traditional health education, in that it is much more targeted towards the individual. That being said, there are some very key core topics that are essential for folks newly diagnosed with diabetes or folks who have been diagnosed for a while and are not managing the diabetes to the degree that they would like to. So some of the sample topics will include things like nutrition and healthy eating, monitoring their blood glucose, getting their A1C tests on a regular basis, communicating with their healthcare provider, making sure that they talk with their provider about the challenges that keep them from managing their diabetes well. We'll also talk about physical activity, and then we'll spend a lot of time talking about medication, the appropriate use of medication, and those sorts of difficult emotions like stress or anxiety or depression or frustration that oftentimes go along with having diabetes, those sort of things that can present large barriers to folks doing the kinds of change that they need. If someone is having challenges with stress and frustration and depression, it's really hard for them to focus on healthy eating. And so we cover a wide gamut of those activities during the 6-week program. The process by which the Diabetes Self-Management Program is delivered is as important, if not more important, than the actual curriculum itself. And the reason we say that is that the process that we train folks through during the 6 weeks is designed to get them to start making small, incremental behavior changes that they can maintain after the 6 weeks is done. So those behavior changes, those incremental changes happen because we talk about things like problem solving those challenges that come up to us in reaching our goals. The participants will also spend a large amount of time sharing their experiences in having diabetes, including the difficult emotions and the challenges that go along with having diabetes. And they will each week set a weekly action plan. And it is that weekly action plan that many of the participants share with us has been the most significant tool to help them move forward with managing their diabetes. So if you can envision for a moment, many participants have come from their healthcare provider with some really good information about what diabetes is, and then are asked to go home, make changes, come back in 3 months after you've lost 10 pounds or 20 pounds or whatever the case may be. So they have that good knowledge. They have some good ideas as to what they need to be doing. This program then comes in and helps them to start making those small changes. So participants may come to the workshop during week 1 with this idea that their goal is to lose 20% of their body weight in order to better manage their diabetes. We all know how challenging that can be. So instead of having them be faced with that overwhelming goal, we help them to reframe their goals into weekly action plans. So yes, it's important to lose 20% of my body weight, but this week I'm going to go for a walk, and I'm going to do that 4 days this week, and I'm going to go for 30 minutes at 8 o'clock in the morning. That very specific, manageable action plan is something that is much easier for participants to get their head around and to see themselves being successful. And if they're able to do those kinds of small behavior changes week to week, adding on more and more, before we know it, they're closer and closer to their overarching goals of better managing their diabetes. And they have much stronger confidence that they'll be able to continue to manage their diabetes as a partnership with their healthcare provider moving forward. It's not often easy to get folks to commit to these kinds of programs. So we use a variety of different engagement strategies in order to talk to folks about what the diabetes self-management program is and how it can fit into their lifestyle. Many of the leaders who offer these programs and the coordinators who manage these programs are trained in motivational interviewing techniques. So we're not trying to get them to sign up for a workshop because their doctor told them they had to, but instead because the workshop will help them reach their life goals, whether that's to spend more time with their grandchildren, to be able to be as social as they were 5 years ago. So the motivational interviewing strategies have helped with participants' engagement and recruitment. And then for each workshop, we also hold what we call information sessions before the 6 weeks begin, so that folks get a really good idea of what the program is and what it isn't, and they're much more likely to participate, stay engaged, and complete the program, as Margie said at the beginning of the presentation today. The Diabetes Self-Management Program is a certified evidence-based program, meaning it has been through the research ringer in a variety of different community settings with a large variety of different populations. And the research has demonstrated that the program is effective, not only in helping folks to make behavior change, but also in maintaining those changes and having those changes have a positive impact on their health. For example, in one of the research studies done with a group of Latino older adults with diabetes, it was a randomized controlled trial. They followed the participants for 6 months, a mix of men and women in this group, a fairly even mix of men and women, compared to a control group, a group that did not participate in the diabetes self-management program. The participants in the diabetes self-management program had lower A1C levels. They reported less health stress. They had fewer hypo or hyperglycemic symptoms, and they reported overall better self-confidence, better self-efficacy in managing their diabetes. And these outcomes that folks reported were maintained over a longer period of time. So even 18 months, a year and a half after the workshop, compared to baseline, The diabetes group, again, had lower A1C, decreased health distress, better self-reported health, improved confidence and self-efficacy, improved communication with their provider, and probably very important for those of us that are looking at quality, in addition to health and care, there were fewer emergency room visits over the last 6 months for participants who had completed the diabetes self-management program than there were for those participants who had not. So these research studies have really been done over a large population. I'm happy to share additional research information with anyone that's interested. But in summary, the program does really look at that behavior change component. So it's not just giving them the information. That's the first part of the process. Much of that they get in clinical systems, but they now get the support to start making small incremental behavior changes. We have participants that oftentimes tell us it's baby steps. That's what works for them, the baby steps. People have reported improved self-efficacy to manage their diabetes, improved A1C scores, and those benefits are all maintained for long periods after they have completed the program. It really has been a powerful partnership here in Massachusetts with the folks at Health Centrics and the QIO. The network in Massachusetts has the capacity to reach participants with diabetes in almost every community of the state, if not every community. And these kinds of networks are only possible through partnerships. These kinds of networks are also popping up in many, many other states. I know we have a lot of folks from Connecticut on the line here, and folks at Connecticut Care Connection are leading a network in Connecticut. There are folks in Maine, led by Spectrum Generations, that are leading a similar network in Maine, and the same can be said for many other states like California, Texas, and Florida. So if you're interested in learning more about the network of diabetes self-management program providers and the different partnerships that are happening in your state, please do reach out to me. My contact information is here on the screen, and I'm happy to connect you with the folks in your organization, in your state, that are partnering with the quality improvement organizations and otherwise to bring these important programs as another tool not only to older adults and adults with diabetes in the community, but also as a tool in the toolbox for many of the different healthcare providers who are there. And with that, I'll now transition over to one of those really powerful healthcare providers here in Massachusetts, Dr. Milagros Abreu, who will talk a little bit more about her experience. So, Milagros, I'm going to go ahead and pass over to you now.
Thank you, Jennifer, and thank you to Margie for those wonderful statistics, and to New England QIO for this opportunity to share our experience and also some information about the benefits of this evidence-based program, in particular to minority populations such as Latinos. So just quick definitions about some of these evidence-based programs. The diabetes self-management education is the process of facilitating the knowledge, skills, and ability necessary for diabetes self-care. The diabetes self-management training is the same program. The only difference for this program is they have been provided or trained or facilitated by a health professional who has certifications to provide this education and can be also being reimbursed by some insurance like Medicare Part B. It also has the potential and opportunity to be offered to rural areas for people who cannot travel, and can be offered via telehealth. Jennifer was mentioned about the diabetes self-management program from the Stanford University. One of the other evidence-based programs is the Chronic Disease Health Management Program. And all these programs have been proven to be effective and to improving health outcomes for minorities. If you want more information also about our organization and our locations, you can feel free to go to our website. So the Latino Health Insurance Program, our primary mission in the state of Massachusetts is to improve access to medical care, improve access to food, and to improve health literacy for minorities in Massachusetts while reducing medical costs. And when we're talking about Latinos, it's anybody who has either born or has an ancestry in a Latin American country. That also include Portuguese speakers or Brazilians and indigenous groups. Some of the benefits that we also provide to this program that we offer in our agency is to prevent the progression of conditions such as prediabetes to diabetes, to prevent the acute or chronic complications for chronic conditions like diabetes or hypertension, and to promote better health through health literacy and education that this evidence-based program allows us to do. So these individuals can be proactive about their health and be the center of their own care. We also, through this program, try to reduce or eliminate healthcare disparities, and also social determinants of health can really impact the decisions for these individuals to obtain health care. So just an overview about this presentation. We wanted to talk briefly about some of the statistics that are affecting these individuals to obtain medical care, some of the chronic conditions that are more prevalent for these individuals, such as diabetes and obesity, the barriers and obstacles that these individuals face, and the benefits of these programs so they can improve their health outcomes. We also wanted to share our referral process and some of the results of those who have been participating in this program. As you can see in the illustration, this is a work that has to be conducted by everybody in the healthcare system and also the partners in the community, as these individuals are lacking so much of information, and it is beneficial for us to bring this information in a way that it can be easier to understand and also available in the different communities. So Latinos and overall are high risk for diabetes. And also the projections that this community will have a higher proportion in 2016, corresponding about 30% of the U.S. population. We also are seeing that compared to white non-Latinos, Latinos have a higher prevalence for diabetes for adults, but if we can see breakdown by the ages, from children to adulthood, the prevalence for Latinos to being obese and overweight is higher. So the risk also to developing diabetes in the following years is also tremendous. So it's also some of the statistics show that by eliminating these inequalities in health and by reducing and improving access to these programs, we can reduce medical expenditure in a number of ways. $1 billion, even for improving, reducing the lost wages, and also they are estimated that $250 billion can be attributed to premature death. So the pattern also in our state, we are working with our partners to increase access to this program because the risk for these individuals to have to become diabetes or prediabetes is high. In some of our communities, the prevalence of being obese and overweight is high. And also there's high prevalence for diabetes among the Latinos, and other ratio of ethnic minorities is higher than the white community. But we also have identified, based on different reports, that being low income and being a minority in some of our cities and towns can also be a factor for these individuals to develop in these diseases. So we need to take in consideration that these individuals have barriers and obstacles that can limit their access to care, so they are most likely to be disconnected from the healthcare system. They are less likely to have a regular doctor. They are also less likely to have visited a doctor in the past year, and they are also less confident to their ability to understand and to manage these chronic diseases. So that's why the information and being able to assess this program can help not only the individual but also the community and the providers, so these families and these individuals can achieve their health. So some of the results that I wanted to share briefly is their report about their overall health. So before they join our interventions or education programs, they also report about their overall health. In a group of these participants, the majority of them report that their health was fair. So our program, the Diabetes Self-Management Education and the Diabetes Self-Management Program, is called Mi Vida Mi Salud, supporting Latino families with diabetes programs. And our primary focus or purpose is to target these individuals and to enhance their support not only for the individuals living with diabetes but also to their caregivers. We are looking for short-term outcomes to reduce the BMI, waistline, A1C. For participants in this program, we wanted to increase their engagement and more healthier behaviors. We wanted to help them to improve their physical activities and their incorporation of more fruits and vegetables in their diet. As we can see in the illustrations that I share today, this is a work that has to be also in part with their caregivers. As we know, caregivers are an important part of the individual's health and the overall health of their family members. So by providing this program not only to the patient but also to the caregiver, we are looking to help these individuals to have the support, coping, and improve health outcomes. Activities to these programs include to provide the education, that will be the diabetes self-management education, diabetes self-management training, the chronic disease self-management programs, and the diabetes self-management programs to the individuals who have diabetes and to their caregivers. We also provide support to these individuals by providing assistance to reduce the social determinants of health in an environment that is cultural and linguistically appropriate so they can feel confident, and they also are able to plan their goals so they can maintain their health. And to improve, because our expectation that through these programs, they will successfully improve their health conditions and the lifestyle changes. And the results from these interventions are also available in the future to our peers for peer publication. We also understand that the process of delivering these programs has to be a collaboration with our primary care providers. We have a strong collaboration to our community and clinical linkages, our partners from the Healthy Living Center and other providers across the state, because we not only wanted to be a support for the people with the disease, but also to our partners so they can have information and understanding how we can provide services to these individuals so they can improve health outcomes. So our referral process, we have incorporated a referral process that can be easily utilized by our partners, either clinical partners, community partners, so they can refer their patients and clients for this program to our facility. We have our prevention clinic with diabetes that is conducted by one of our physicians, is a clinical coordinator, a diabetes coordinator, and our physician has met the standards for the American Diabetes Education and Training, for diabetes self-management education and support, and our organization is accredited by the American Diabetes Association to provide diabetes self-management education in our Milford and Framingham offices. So the first step for this referral process is to have that intake or assessment by this clinical coordinator who will assess the needs for the patients and being able to refer these patients to support to these support services that include the diabetes self-management program, other evidence-based programs that are facilitated by our community health workers. We also understand the benefits of having community health workers incorporated into our workflow for our delivering of these services because of their knowledge and understanding about the contract from these individuals. And also to our other community partners for additional support and our patient navigators on site so they can review what are the needs that this patient has to reduce their barriers to care so they can focus about their health and the treatment so they can improve their health outcomes. As you can see, we also going to be sharing this referral process for our audience this afternoon. We also have this information posted in the New England QIO so you can have a better understanding about how this can be incorporated into a clinical settings and also how these programs can be an opportunity for you to expand for your clinical practice to services within the community. As you can see in front of the illustration, this has to be a collaboration from the clinical provider to the community organization or the community program. Anyone cannot do this alone. We have to be, we want also to emphasize that our efforts to provide this education doesn't conflict with any patient's previous treatment or primary care provider recommendation. It's an enhancement and to provide this medical support, counseling, and education so the individuals can fight this disease by helping them to become more proactive about their health and advocate about their health conditions. A more detailed process, like Jennifer mentioned in her previous presentation, the Diabetes Self-Management Education or the Diabetes Self-Management Program. We have, this is a 6-week program, so after the provider makes the referral, we need to speak with the patient to get them enrolled into the program for the support group. And these programs have to have a minimum of 8 participants. So that's why having available in multiple settings in the community, even in the medical practice, but have the opportunity of having your patients or members from the community benefit from this program. So we're going to be showing you how we have been able to disseminate this program and also some of the community partners as well that are delivering this program within the community. So we can meet the standard and the fidelity of the program and at the same time having the opportunity for these patients to receive this program in a community setting or places that are closer to them. So the patients in the step 3, as you can see, we have a class 0 that is explain the patient about the content of the program. The patient also has some of the measurements conducted, and the patient has opportunity to ask questions, and the patient has a better understanding of the overall course or workshop. So the patient made the decision, and this information is sharing with their clinical provider or their healthcare provider or the organization who makes that referral. And after completion of the workshop of the class, that is either 4 out of 6, the patient are able, we are able to also follow up with the patient in continual basis every 3 months to see how the patient continue to maintaining their goals after completing the classes. So this information is documented and also shared with the individual provider who makes the referral. So just to give you a brief example, we included some of the results for these programs and how meaningful has been for some of these participants. We preliminary results for about 200 individuals who participated in this program. They are living with diabetes and also hypertension, and the average age was 60 years old. The majority are females. We also have a high proportion of males attending, and the tools that we use to conduct this evaluation is the questions for behavioral risk factors, the Stanford questionnaires, and the pre and process, and also questions provided by our partners for the New England QIO. Some of the participants, we have a great representation from Latin American countries. So we have 17 out of 19 Latin American countries were represented, and the majority of the individuals who have participated with diabetes are Puerto Ricans, following by Dominicans, and Brazilians and Salvadorians. So as you can see from the slide, there are wonderful results for individuals participating in the health outcomes improvement. So from the weight, reduction of their weight before and after, their BMI, the waistline, and also their A1C. I just only wanted to highlight one of the participants, the client ID number 123 at the end, at the bottom. He had, in the beginning of the classes, 496 pounds and higher BMI, and after a year that he continued in the program, his A1C was 11, his A1C dropped to 8, and now he has been reduced tremendously, an improvement in all these health outcomes. So just to see the weight loss, also some information about the participants in the program who have lost their weight. All the improvement have also been health behavior, so improving in the eating habits and more physical activity. More examples about participants who have dropped even with other evidence-based programs like chronic disease self-management. And one of the most meaningful is their graduation. It's a wonderful opportunity for members also from the community to receive these programs and being offered in multiple locations, so such as health centers, senior centers, and so forth. So the locations for the education in multiple sites being offered by us. And how important is for all of us that are in this call, so to continue delivering this information to the members from these communities, but also in a way that it can be cultural, linguistic, and available in all multiple settings. We also wanted to share some of our different methods, like our magazine, that is available also we have more information about these interventions. You can find them in our website. So in conclusion, these findings, as we all know, learned today, and we all know this in this presentation, that these programs not only contribute for the improvement in the psychological health status, self-efficacy, and healthy behavior, that also these results can be maintaining over time. And we only wanted to thank our partners and collaborators in this effort, and any questions and opportunities to share most of our learning and practices, we will be happy to answer and available to you. So thank you, everyone. And now I'm going to transition to Margie. So thank you.
Thank you so much, Milagros and Jennifer. Appreciate your presentation. It was great. And now I'd like to turn it over to a patient, a recent DSME graduate, my colleague Pat Donovan McLeod, who leads the DSME QIN-QIO effort in Massachusetts, is at the Greater Lynn Senior Services Center with Verdrey, Madzimoya. Verdrey is a recent class graduate. So, Verdrey, I'm wondering if you could spend a minute or two to share your perspective on this class. What was your biggest takeaway, and would you recommend it to others? And if you're speaking, you need to take yourself off mute.
Can you hear me now?
Yes, we can. Very good. Thank you.
Okay. My biggest takeaway is I wish I had had this course earlier. I would absolutely recommend it to others and have already started recommending it to others. And one of my personal recognitions is that I've already started being more active and being more aware of healthier eating. I haven't yet completely eliminated Pepsi, but I've come a lot closer than I have been in the past. And I've had recently the opportunity to visit with family, so I have the challenge to which I didn't quite arise to face, but I had the challenge of educating family about how they could help me eat more healthily. That one is still on the table because I didn't do such a good job on this trip. So yes, in summary, I would absolutely recommend the class. And I think the best thing is the self-awareness about how all of the pieces fit together. So the emotions and feelings and angry reactions to not being able to eat whatever I want to eat whenever I want to eat it. And then on the other hand, gee, I feel better when I take my medicine at a regular time and keep myself on a reasonably regular schedule. Those are the kinds of things that the course helped me highlight and strengthen for myself.
That's great. Baby steps is what we say, right? But it's great to see the successes that you've had with this. So now at this time, I'd like to open it up to discussion. We are running a little short on time, but I think, Nayara, there's a couple of questions in chat. Perhaps we could get to those and get a couple of responses before that.
Yeah, one of the first questions was for Dr. Abreu. In your organization's website, there are a few church sites. Can you speak about what role faith-based organizations play in diabetes clinical care management? How effective are faith-based organizations in educating patients to live healthier lives?
Excellent question, because one of our efforts is to engage the faith-based community, not only because the faith-based community has courses available to reach out to people who have been low income and also individuals who might benefit from this program, but also by training leaders from these churches can help us to expand these programs in different locations and sites in towns and cities in Massachusetts. And faith-based leaders are wonderful opportunity so we can engage more members from the community, not only the church members, but also expand into the entire community and identify those higher needs and a higher risk.
We have other questions, Diana.
The only other one is, would it be more helpful to do waist-hip ratio?
That is also, we do as well waistline because of the benefits. As we know, the digital content can be a strong predictor for us to identify if the patient or the individual has improving their health. So we also incorporate that as part of our measurements. So it is a critical part to identify the improvement, because we know that the centripetal fat and the metabolic syndrome, they are also important factors for us to identify, the complications and also the progress of the disease and also the improvement.
Great, thank you. Any other questions, Nayara?
I'm not seeing any more in chat, Margie.
Okay, great. I would, just because we're a few minutes away from the top of the hour, if there are any other questions, please just put them into chat and we will definitely get back to you so that we can answer your questions. For those pharmacists who are claiming continuing education credit, the ACPE code today is DSME. You'll be able to enter that information when you complete the session evaluation. Others who complete the evaluation will receive a certificate of attendance. If you're interested in learning more about our programs or collaborating with us on your initiatives, please feel free to reach out to the DSME leads in your state. They are listed on this slide for your convenience. As a reminder, the next webinar in our Medication Safety Series will be held on August 22nd. We will hear from some of our partners who will discuss promising practices and how incorporating the pharmacist into the care continuum brings value. So Morgan, I will now turn it over to you to wrap up.
Excellent. Thank you, everyone, for that great discussion. As you can see from this last slide, we are now on social media. So please connect with us on Facebook and LinkedIn for the latest resources, webinars, and other offerings from the New England QIN-QIO. When you close out of this webinar, the evaluation will automatically pop up on your screen. If you could please fill that out, we would greatly appreciate it. If you don't have time to do the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow with the link to the evaluation. This email will also contain a link to the event page on our website, where you can find the PowerPoint presentation. Within the next few business days, a recording and transcript of this webinar will also be added to the event page. Thanks again for attending, and we hope to see you on our next